So good morning or good afternoon. I'm Stephane Heymans. I'm a cardiologist working at the Maastricht University Medical Center in the Netherlands. So I'm a professor of cardiomyopathies. And so my main patient-related work, my main clinical work is focused on genetic and inflammatory cardiomyopathies. So cardiomyopathies means unexplained heart failure in relatively young people. And median age is around 55 years. And around 20% of those people, patients with unexplained heart failure at the beginning, will have a genetic susceptibility, a gene mutation, which will lead to the heart failure clinics. So Titin, which is the topic of today, Titin gene mutations are the main genetic risk factor for dilated cardiomyopathies. So Titin is a very big gene. That's why it's also called Titin. And it's responsible for 1/3 of all genetic dilated cardiomyopathies. And it's a specific region in this Titin protein, the A band, where mutations that lead to an incomplete protein, the mutation in that part of the Titin genes are pathogenic. And as said, so 1/3 of all gene mutations in dilated cardiomyopathies are within the Titin genes. And all over the group, all over the phenotype of dilated cardiomyopathy, approximately 10% will have a pathogenic mutation within this Titin gene and protein. It's also present depending on the population studied. In healthy controls, it's present in 0.1 to 1% of the general population. So it's a genetic risk factor, a susceptibility to develop heart failure. So what's the mechanism behind the development of dilation or cardiac dysfunction upon a Titin gene mutation? So the Titin mutation itself will lead to a partial loss of the healthy normal Titin protein, which will lead to a decrease of the functional contractile elements of the heart, and will also lead to dilation, as this Titin protein has an important function both in the function, the contractility of the heart, as well as in the structure, maintenance of the normal structure of the heart. So that's why loss of this Titin protein will lead to both cardiac dilation and dysfunction. As said, its Titin gene mutations are a kind of genetic susceptibility factor. So not all people carrying a gene mutation in this gene will develop cardiac disease. So it's estimated that approximately 50% of gene mutation carriers within the Titin gene will never develop heart failure or dilated cardiomyopathy. And so that's why this genetic susceptibility gene often requires an additional acquired disease during life to develop the disease, the so-called second hit. So if one person would carry a Titin gene mutation, on top of that, if, for example, there would be viral myocarditis, autoimmune disease, chemotherapy, that would also affect the heart, the combination of the genetic susceptibility gene Titin together with this acquired diseases during life will unveil the genetic risk to develop a dilated cardiomyopathy. So that's why also in many clinical studies, it has been demonstrated that these Titin gene mutations are quite prevalent in both unexplained heart failure, idiopathic heart failure, as well as in acquired cardiomyopathies. What does it mean? So in approximately 8 to 15% of patients with, for example, alcohol abuses-related heart failure, chemotherapy-related cardiomyopathy, but also in acute myocarditis, so viral infection of the heart, leading to heart failure. So in up to 10% of those patients, a gene mutation in the Titin gene will be identified. So the development of heart failure or dilated cardiomyopathy upon a Titin gene susceptibility often requires the interaction between, on one hand, the gene mutation in Titin, the genetic susceptibility, and on the other hand, an acquired disease second hit. Even normal things are like a pregnancy and the hormonal changes at the end of the pregnancy and during the delivery may also be a disease modifier, and together with the genetic susceptibility of Titin gene mutation will lead to a dilated cardiomyopathy. And so a question that I often get is, do we need to screen for this Titin gene mutation in all healthy people? I don't think so. First of all, it will be very costly. It's not cost effective. Secondly, we know that up to 50% of persons carrying this gene mutation will never develop the disease. And on top of that, it would give a lot of anxiety to people carrying this genetic susceptibility. But still, it's an important genetic factor. So, for example, I remind a person, a lady, 36-year-old, during the one of my last duties in hospital. She just delivered her first baby, and she had a decreased cardiac function with symptoms of shortness of breath and fluid retention. And then she told me that that her mother was also well known with this genetic susceptibility in the Titin gene. And then indeed she performed genetic testing, and she also carried this genetic risk factor, which together with the pregnancy led to the development of a dilated cardiomyopathy. So also acute myocarditis, which is a viral infection of the heart leading to exaggerated inflammation in the heart, together with a Titin gene mutation, can facilitate the development of a dilated cardiomyopathy. So what about the disease progression and the treatment? So the Titin gene at the whole beginning, when it was discovered around, I think now 20, 30 years ago, was seen as a kind of benign gene mutation, because we do see that within the first 1 to 2 years after diagnosis, with instauration of standard heart failure drugs, we often see in more than 70% of those patients a rapid improvement up to a recovery of cardiac function, up to a normal cardiac function. But still, now with the follow-up of 10, 20, 30 years of those patients, we do know that there is a persistent risk of cardiac dysfunction. And that's why a follow-up of cardiac function and also possible arrhythmias, which is the case for every genetic cardiomyopathy, is required for every 6 months up to 2 years, depending on symptoms, medication, and duration of the disease. So which drugs, which medication would you need as a patient with a Titin mutation-related cardiomyopathy? It's simple. You just need standard heart failure drugs. We call it the golden four. Those are the same drugs as a patient with a myocardial infarction or valvular heart disease would get. So, because which symptoms could you develop upon Titin cardiomyopathy? Also, the classical symptoms of heart failure being shortness of breath, dyspnea, we call it, shortness of breath, fluid retention, which can be recognized as a sudden increase of your body weight, like more than 2 or 3 kilograms within 1 week time, and also being fluid retention in the ankles, in your lower legs, where you can have some pitting edema, where you can make little pits in your lower legs. And medication is indeed targeting the cardiac dysfunction and dilation. So we want to lower the adrenergic drive. We want to dampen the reflex of the body to retain fluid and blood. But also we target the metabolic changes in the heart. So that's why you would get normal heart failure drugs such as beta blockade, angiotensin 2 receptor antagonist, aldosterone antagonist, and also a new drug lately, which is a diabetes drug, but also given to heart failure patients as it rebalances metabolism in the body. And sometimes in the end stage or when cardiac arrhythmias are present, a defibrillator to prevent life-threatening arrhythmias. A defibrillator may be implanted. And also, if the heart would not beat in a synchronized manner, one can implant a so-called cardiac resynchronization device, either not combined with this defibrillator. So as said, possible improvement recovery of cardiac function within 1 to 2 years, with the risk of still developing heart failure at long term, and exceptionally in the end stage, cardiac transplantation may be required. So which would be the symptoms that would alert you, and when would you have to go back to your doctor? So if the shortness of breath would appear, so increasingly, like being short of breath when going on, when just walking in the street or when working in your home. So then that's an alarm symptom. Also, a rapid increase of body weight and fluid retention. And then an important symptom related to dangerous cardiac arrhythmias is many syncope, so unexpected sudden loss of consciousness, which may indicate life-threatening ventricular arrhythmias. And sometimes you may also sense those arrhythmias as rapid palpitations. So treatment, again, it's classical heart failure drugs, but we also, and many university centers together with industry, are developing so-called gene therapy. We are not yet there. It's in the early stage of development, and first small clinical trials have been started. So the future is to have either a gene-specific treatment, so where we treat molecular, so changes in the heart, which are the direct consequence of a specific gene mutation. Like for the Titin gene, we know that there are very strong metabolic alterations, oxidative stress, inflammation, scarring of the heart. So we hope to identify the main causes, targets, or consequences of a Titin gene mutation leading to cardiac changes. So we could hope that there might be a pill, a drug specific for Titin cardiomyopathies. The hope is, of course, is that we could specifically change or correct the gene mutation. So there are different ways to do so. For Titin, as it is such a big gene, we cannot just overexpress the correct gene. The gene is just too big for that. Still, companies and academia is working on skipping, taking away the part of the gene which leads to a deficient, to an abnormal or absent protein. That's so-called gene skipping, exon skipping. Other people are working on silencing of a wrong gene, but that's not the case for Titin, as Titin gene mutations mainly lead to a decrease of the normal protein. And then there is also new technology, which got also a Nobel Prize a few years ago, CRISPR-Cas, where we try to, with a specific system, correct the gene and so put in or take away the mistake, let's say. But for Titin, it's either a correction of the gene mutation or taking away the bad part in the gene where the gene mutation is present. So with that, I would like to end and recapitulate. So first of all, the Titin gene mutations are the most prevalent risk factor, genetic risk factor in unexplained, non-ischemic, non-valvular heart disease. So it's present in about 10% of all patients with dilated cardiomyopathy, and it's responsible for 1/3 of all monogenic DCM, dilated cardiomyopathy. It's a classical genetic susceptibility gene for heart failure and probably present in up to 1% of the healthy general population. So it's a second hit. So it means that this gene susceptibility, together with, for example, chemotherapy, may lead to heart failure. The future of treatment is to get gene-specific treatment or gene therapy. And the important message, both for the general population, but also for the medical society, is that you have to look for this genetic susceptibility factor, as once identified, you can not only help the patient, the affected person, but you can also discover this genetic susceptibility factor in family members. For every patient, probably there are 3 family members with the same genetic risk factor, and an early detection of heart failure in family members may improve the long-term outcome of those family members. And of course, you could also prevent heart failure and, worst case scenario, sudden cardiac death. With that, I would like to end my talk, and always happy in the future to address questions.
This video is part of a series of educational videos developed by the Genetic Cardiomyopathy Awareness Consortium and brought to you by the DCM Foundation. Our goal is to connect you with the leading experts in the field of cardiomyopathy to further your understanding of this disease and to provide resources to help you manage your care. Thanks for watching.